For this video, we will be focusing specifically on agents used for the treatment of diabetic peripheral neuropathy. And we are going to use this as an opportunity to review some of the definitions, concepts, and drug classes we already discussed in other videos when talking about pain, as well as integrate a few new classes, but now in the context of diabetic peripheral neuropathy. And I'll probably just call it neuropathy for the remainder of the video. So like usual, we're going to start off with normal pain signaling, which we already discussed some in the opioid video back in block 4, but now we're going to add a little bit more detail, but still keep it pretty simplified in general for right now. So we start with some sort of peripheral noxious stimulus that activates nociceptors, which are just sensory neurons for painful stimuli. So if this activation reaches a particular threshold, this triggers an action potential peripherally that will then propagate along the axons of that primary afferent sensory neuron through the opening of voltage-gated sodium channels. So sodium ions come in for depolarization, which triggers the nearby sodium channels to open and so forth, propagating that action potential until it reaches that presynaptic nerve terminal. This action potential arrival will trigger the opening of voltage-gated calcium channels, increasing those intracellular calcium concentrations locally. Once the calcium concentration reaches a certain threshold, this is going to mobilize those synaptic vesicles that contain neurotransmitters, which will then fuse with that presynaptic membrane, releasing things like glutamate into the synapse, which is an excitatory neurotransmitter that binds AMPA and NMDA receptors on the postsynaptic membrane of second-order neurons. So both of these receptors are ionotropic, meaning that they're coupled with ion channels that allow the influx of cations to propagate that action potential that started in the primary afferent neuron. There is also the release of substance P, which is a neurotransmitter that binds the neurokinin 1 or NK1 receptors on the postsynaptic membranes, and these are GPCRs that lead to a number of downstream effects that further promote this excitability and that propagation of the action potential. So for this video, we are going to focus on this particular synapse, but know that these action potentials will travel similarly down axons and across synapses up the ascending pathway to the brain to be perceived as pain. So based on the schematic, you can probably guess that this signaling cascade is not that simple because there are ways in which the signaling cascade can be modulated, particularly by the descending inhibitory pathways from the brain. And we are going to focus only on inhibitory signals at this presynaptic terminal of that primary afferent neuron as our example, but just keep in mind that these inhibitory signals can also act upon other levels involved in the ascending pain pathway. So these inhibitory signals can prevent that pain signal from further propagation upwards. So these neurons involved can lead to direct and indirect inhibitory signals. Directly, these signals can lead to either the release of norepinephrine, which will then act upon alpha-2 adrenergic receptors found on those presynaptic nerve terminals. And these receptors, if you remember, are coupled to GI, so I won't go into this signaling cascade any further because you should be very familiar with that. But downstream, this will inhibit glutamate and substance P release. Or these signals can lead to the release of serotonin, which will then act upon certain serotonergic receptors that are found on that presynaptic nerve terminal. These are also coupled to GI, downstream leading to that inhibition of glutamate and substance P and other neurotransmitter release. And we will wait to discuss specific serotonin receptors in a later video in this block. So indirectly, the release of these neurotransmitters from these inhibitory neurons can also act upon local interneurons, activating them to release things like specific enkephalins and endorphins, which remember are endogenous opioids that will bind opioid receptors like our mu-opioid receptors on our presynaptic nerve terminals, which are also going to be coupled to GI and inhibit that neurotransmitter release downstream. Also, in a similar fashion, these inhibitory signals can also lead to the release of GABA from nearby GABAergic interneurons, which is a neurotransmitter that will bind one type of GABA receptors that are ionotropic, but this time will lead to the influx of chloride ions. And this will counteract that positive ion influx that's helping to propagate that action potential. And this will downstream inhibit that neurotransmitter release as well, which makes sense if you think about this action potential propagation. So together, the transmission of pain signals along with these modulatory inputs combined results in the perception of pain due to that noxious stimuli. But now, if this is what leads to pain perception, where in this pathway do imbalances occur that lead to the inappropriate perception of pain that is behind this diabetic peripheral neuropathy? So moving to our next slide. General peripheral neuropathy is thought to result from some sort of peripheral axon injury, and this pain is perceived without any sort of noxious, painful stimulus, and is usually described as either pins and needles sensation, a burning sensation, or tingling and numbness. The mechanism behind this inappropriate pain perception is not clear, but there may be an increased excitatory state from either ion channel distribution changes, or there can be impaired descending inhibitory pain pathways leading to this pain signaling imbalance without any stimulus, or a stimulus that shouldn't be painful. Specifically now in diabetic peripheral neuropathy, the thought is that the chronic hyperglycemia is what leads to that peripheral neuropathy, but it is not clear exactly how. But we know that it starts distally, generally affecting the feet first, and then further progressing. And there may be multiple mechanisms, two of which most think of first is either direct glucose toxicity or neuronal ischemia due to microvascular changes. So because of this, step one for the treatment of diabetic peripheral neuropathy is achieving optimal blood glucose control, which can prevent and or slow the progression. But unfortunately, this peripheral neuropathy cannot be reversed. So this means optimizing the patient's diabetic treatment regimen for either type 1 or type 2. And counseling to promote adherence is going to be key. So for this week, I have also included the type 1 and type 2 diabetes pharmacology videos from block 2 if you need to review those agents for it. Once we have optimized the patient's diabetic treatment regimen and emphasized the importance of glycemic control, what agents do we have available to provide analgesia in the setting of neuropathic pain? And the first line treatment options are not your usual pain treatments. And most of the agents we will discuss fall into the category of adjuvant analgesics, which basically means that these agents were originally indicated for something other than pain, but can relieve pain in certain conditions, like when we have no painful stimulus, but imbalance and inappropriate pain transmission. So moving to the next slide. So the first group of adjuvant analgesics we're going to discuss are the gabapentinoids, which includes gabapentin and pregabalin. And these agents were originally approved as anti-epileptic drugs, or AEDs, or anticonvulsants, but now they are primarily used as an analgesic in this adjuvant role. So based on their name, you would assume that gabapentin and pregabalin work by binding the GABA receptors. And they were actually originally designed to look like GABA and exert this effect. But they actually do not bind GABA receptors. And instead, these are going to bind to the alpha 2 delta 1 subunit of the voltage-gated calcium channels. And this is going to inhibit that calcium influx that's necessary for the mobilization of those neurotransmitter-containing vesicles. So these agents still inhibit inappropriate propagation of signals by preventing neurotransmitter release, but by actually acting as a blocker of these calcium channels. So because we're altering neurotransmitter release, eventually over time, you can imagine that this may lead to some neurotransmitter changes and receptor regulation. And this is why that these may not fully provide pain relief acutely and may take a few weeks to see maximal effect, which is going to be a theme for the adjuvant analgesics. So both pregabalin and gabapentin are thought to be relatively safer pain relief options when compared to traditional analgesics like our opioids, which, remember, come with that risk of respiratory depression and substance use disorder and other concerns that we discussed previously, which is why when looking at the controlled substance schedule of these agents, a lot of opioids are going to be Schedule 2. meaning there is a high potential for misuse or abuse, with use potentially leading to severe psychological or physical dependence. Whereas pregabalin is a Schedule 5 drug, where Schedule 5 drugs have the lowest potential for misuse or abuse when compared to all of the other controlled substance schedules. The risk is still there, but much less risk. And gabapentin, which is not a controlled substance at the federal level, but some states do consider it a C5 or a controlled substance Schedule 5 drug, and other states, like in Ohio, may require additional prescription drug monitoring for gabapentin that is similar to what is required for controlled substances. So since these two agents are generally safe and well tolerated, the risk of adverse drug reactions and drug-drug reactions are pretty minimal with these agents when used alone. So more of a risk of adverse drug reactions like dizziness, drowsiness, and blurred vision, and peripheral edema with pregabalin when compared to gabapentin. However, these agents are listed on the Beers criteria list of drugs to avoid in older adults, especially those with reduced renal function, because of the risk of sedation and ataxia leading to an increased risk of falls. Also, notice how I said that these agents were relatively safe alone, but combining these agents with other CNS active agents like benzodiazepines, which we'll talk about later on in this block, opioids, alcohol, and others, may lead to additive sedating and depressive effects. But also when combined with opioids, for example, it can lead to euphoria, increasing that risk of misuse, which is a big reason as to why pregabalin and gabapentin are either a C5 or their prescribing is monitored. So now we will revisit these agents again later in the block, so keep these key points in mind that we discussed today, and think about how their mechanism that is beneficial for neuropathic pain may be effective as an anticonvulsant, for example. So moving to our next slide. The next two classes of adjuvant analgesics are both classes of antidepressants. And we will first start off by discussing the relatively older class of agents known as the tricyclic antidepressants, or the TCAs. And these are going to be things like amitriptyline, nortriptyline, and cypramine. So before we discuss their mechanism of action, we first need to talk a little more about norepinephrine and serotonin signaling at these synapses. So we know the descending inhibitory pathway exerts its effect on our presynaptic nerve terminal by releasing either norepinephrine or serotonin, which will bind its respective receptors, and when no longer needed, we need to have a way to turn off this signal. Otherwise, we cannot propagate pain signals at all, whether they be appropriate or inappropriate. And one of these ways is through these reuptake transporters, which will move excess neurotransmitters from the synapse using this transporter to recycle that neurotransmitter back into vesicles to be ready to go when that next inhibitory signal is needed. So in diabetic peripheral neuropathy, we have extra inappropriate pain signals that if we could turn off by leaving that excess norepinephrine or serotonin in that synapse, we could end up with more pain signal inhibition. And remember, one of the thoughts is that there is a reduction in these inhibitory signals, promoting that imbalance in neuropathy. And this is where the TCAs come in, because these agents will bind and inhibit both the norepinephrine reuptake transporter as well as the serotonin reuptake transporter. So more of these neurotransmitters remain to bind those serotonin or alpha-2 receptors to increase those inhibitory signals and provide some balance and hopefully pain relief. So the second class of antidepressant agents are the serotonin norepinephrine reuptake inhibitors, or the SNRIs, which provide their analgesic effect in the exact same manner as the TCAs, just as their name suggests. So agents like duloxetine and desvenlafaxine, for example, will inhibit these reuptake transporters, increase that potential for inhibitory signals, and reduce those pain signals. So not only do these two classes share the same mechanism of action, they also share a common metabolic pathway via CYP2D6, which, remember, has the potential to be affected with drug-drug interactions as well as pharmacogenomic considerations. Are generally started low and titrated up, and if need to be discontinued, patients have to be tapered off of these to avoid withdrawal symptoms. Now, the main difference between these two classes is their side effect profile. So regardless of if we are talking about a TCA or an SNRI, we're going to have the risk of side effects that reflect alterations in norepinephrine as well as serotonin. So changes in heart rate and blood pressure for norepinephrine, and the ones for serotonin we will actually get into more depth in a later video in this block. But the SNRIs were developed along with newer antidepressants to provide more selective serotonin and norepinephrine reuptake transporter effects than the TCAs. Because in addition to these effects, the TCAs also block histamine 1 receptors, which leads to significant sedation, and also blocks muscarinic receptors that leads to cognitive impairment and the slew of anticholinergic side effects, which, remember, will be the opposite of our dumbbells mnemonic that we've talked about in other videos. So think about drying the patient out, and those are going to be the sort of side effects that will come with our TCAs. So now, as I said, we will talk about these two classes of antidepressants in more depth later on in this block, but this makes sense how altering these neurotransmitter reuptake transporters can promote these inhibitory signals acutely. And then with long-term treatment, these changes lead to modulation of neurotransmitter levels and receptor regulation, helping to normalize this pain signaling pathway. But because of this, it's again going to take several weeks to get those full analgesic effects. So moving on to our next slide. Now, we already discussed one class of antiepileptics that can be used as adjuvant analgesics, but another class of antiepileptics, like valproic acid or VPA, that have sodium channel blocking activity, can also provide relief in the setting of neuropathic pain. And this is because these sodium channel blocking AEDs bind and inhibit these voltage-gated sodium channels that are essential for this propagation of action potentials down the axons to reach those presynaptic terminals to start that calcium influx and that further propagation. So these agents specifically lock these sodium channels in their inactive state so that their recovery is delayed. So without these channels functioning, we lose the inappropriate pain signal propagation. So of the agents in this class, many also have additional effects, but this is the main one thought to be beneficial in neuropathic pain. Also, again, because we are altering that neurotransmitter release, this may lead to some neurotransmitter level changes and receptor regulation, and is going to take a few weeks to see maximal effects. Now, we aren't going to spend too much time on this class of AEDs beyond their mechanism of action because there's a lot of considerations when it comes to these agents, and it's going to vary between the agents in this class. And not all of the agents in this sodium channel blocking class are commonly used for neuropathic pain. So instead, we'll just mention some general pharmacologic considerations that we'll address in more detail in future videos. So for most of these agents, P450 enzymes are going to play a key role in their metabolism, and some agents may even be CYP450 inducers. So we're looking out for a lot of drug interactions. Several are also highly protein bound. So again, big concern for drug interactions there as well. Many of these are teratogenic. So this will be a big concern, and there is quite a list of adverse drug reactions that I won't get into that will require starting low and titrating up slowly for most. So even though we haven't gotten into specific agents here, you can see that because of some of these risks, this explains why our gabapentinoids are generally more common for this neuropathic pain indication than these anti-epileptic drugs, but they are still options. So moving on to lidocaine. And now the reason we are going to discuss topical lidocaine on this slide is because topical lidocaine is also thought to reduce this inappropriate pain signaling by blocking those voltage-gated sodium channels as an anesthetic. And actually, its antiarrhythmic effects are from a similar sodium channel blocking effect. This is just systemically targeted at the heart. So when lidocaine is used topically as either a gel or a patch, we can achieve local neuropathic pain relief and have minimal systemic absorption as long as the lidocaine is applied appropriately. And mostly we're only really worried about local skin reactions. So we want to make sure that these patches or gel is not applied to broken skin. Heating pads aren't used over the patches. There's no application beyond the recommended dosing, etc. So these may require more counseling. So very similar mechanism of action for the other anti-epileptic drugs and lidocaine, but very different pharmacologic considerations. So moving on to the next slide. So our last group of agents are actually recommended second line or as an add-on to the first line agents or when pain relief is needed acutely, while we wait for the other classes of agents to kick in over the first few weeks of therapy. And these are going to be our opioid receptor agonists. Now, I won't get into opioid specifics since this is not the first line therapy and we've already gone over the mechanism of action and important pharmacologic considerations in past videos, which I will also include this week in case you need a refresher. So now, based on our discussion comparing gabapentinoids and opioids, you can guess why these are second line and not preferred, because we highlighted that these agents are relatively more risky for this particular indication because that risk of misuse and adverse drug reactions, and also because there is weak support for their long-term efficacy. However, even though these are second line or add-on therapies, I do want to mention that several opioids like tramadol and tapentadol exert their analgesic effects through both their activity at the opioid receptors, but they also have SNRI effects. So inhibition of those reuptake transporters, so more of a dual mechanism of action. So it is thought that this would be an added bonus in neuropathic pain, and you may still see these agents being used inappropriately. So just be aware that their novel dual mechanism is likely the reason behind their inappropriate use before trying those other first-line agents. So moving on to our last slide. In summary, the mechanism behind diabetic peripheral neuropathy is not completely understood, but two things are very clear. First, hyperglycemia must be corrected through optimization of diabetic treatment regimens and the promotion of patient adherence to prevent or reduce progression. And if you need to revisit any of the agents commonly used in type 1 or type 2 diabetes, please revisit the videos from block 2 I have included. So second, the treatment of diabetic peripheral neuropathy involves a number of adjuvant analgesics that are not generally the classes of agents that come to mind first when thinking about pain relief. But once you think about the pathophys that we discussed today, and how it involves that inappropriate pain signaling when there's no stimulus present, these agents make more sense because it all comes down to altering neurotransmitters to prevent that propagation of inappropriate signals. And to just end on a key pharmacology-related counseling point, in order to really ensure these adjuvant analgesics are given a real try by patients, it'll be important to set pain relief expectations, and then it may take several weeks to see maximal effects. Ideally, this will help avoid an inadequate trial of a first-line agent requiring a switch to these second-line, more risky opioids that may not be effective long-term.